Okay, I think we're going to get started here shortly. Good morning or good afternoon, depending on where you are. Welcome to our Global Health seminar on what we need to know before the next pandemic, which is our regular Tuesday Global Health webinar at a little bit different time to accommodate some of our speakers who are scattered across the globe. I'm Jim Conway. I'm one of the associate directors at the UW-Madison Global Health Institute, and we host this series. I'm also one of the directors of programs at the School of Medicine and Public Health and the director of the Office of Global Health. The Global Health Tuesday seminar series features researchers and practitioners from the University of Wisconsin, as well as from across the world, and really represent colleagues and partners globally. These speakers really showcase the complexity of global health challenges and the many kinds of expertise needed to address them. By sharing their experiences with the campus and the Madison community, our guests provide insights into global health, encourage conversation, and help connect colleagues locally and globally. And I think today's topic is going to be a great example of that. Just as a quick announcement, we'd love to see all of you on April 19th for our annual Global Health Symposium, which is entitled this year, Making Connections, Health, Climate, and Equity. The symposium is going to be a combination of both in-person and also live streamed in this new hybrid world that we're all entering. And we're really excited, though, to be able to host on campus a majority of people being able to be there in person together. You'll be able to find all the information and register for the meeting at our website, ghi.wisc.edu. Finally, our final Global Health Tuesday seminar of the semester is going to be on April 26th, when this year's cohort of our planetary health graduate scholars are going to present their work. Today, you should all be muted as you're entering. If you've got questions or comments that you'd like to share, we'd ask you to please put them in the chat. We've got a fairly large audience today, and we'll have time for your questions after the main discussion here. I'm really pleased to be able to introduce and welcome 4 distinguished panelists from across the globe that are going to share this conversation today. In no particular order, Christian Happy is a PhD and professor at the Department of Biological Faculty at Redeemers University in Nigeria. He's the center leader for the African Center of Excellence for Genomics of Infectious Diseases. Amandine Gamble is a DVM and PhD postdoc researcher currently at UCLA in the Department of Ecology and Evolutionary Biology and studies spillover of organisms between humans and animals. Stephen Morrison is a PhD, is a senior vice president at the Center for Strategic and International Studies and director of its Global Health Policy Center. And last but certainly not least is Nasia Safdar, who's an MD, PhD, a professor of medicine and an infectious disease specialist, and is the inaugural associate dean for clinical trials here at the School of Medicine and Public Health and research director of the new Wisconsin Medicine Institute for Clinical Trials, but has been really one of our lead clinical people here in the infection control side of things, as well as a regional expert throughout the pandemic. So please join me in welcoming our panelists. And I'm going to basically start out and give each of them a chance to introduce themselves and give a little information about what their particular role during this pandemic has been as we've tried to manage something that has obviously been a much longer and deeper slog of a challenge than any of us had expected. So I'll start out with Christian. Christian, can you just briefly unmute yourself and introduce and talk about your role with this pandemic?
Yeah, Christian Happy is my name. I'm directing the African Center of Excellence for Genomics of Infectious Disease at Redeemers University in Nigeria. I've definitely worked through several epidemics in Africa, from Ebola to, to monkeypox, Lassa fever, and then yellow fever. But this pandemic specifically, so I've been involved in supporting the African continent at the level of the African Union in order to respond to the pandemic as a member of the Africa Task Force. But I also have been involved in building capacity on the continent. In the context of this pandemic, my lab has trained, scientists from over 32 different African countries. And also where we sequenced the first SARS-CoV-2 genome in Africa, and really paving the way for genome sequencing, and also helping the continent to respond to this pandemic. We've, in the process, have been able to sequence COVID sample from about 30 African countries, making the data actionable, and using the data to help the continent to respond to this pandemic broadly. And if you can see exactly the impact of the work that we've done, is really reflected on the fact that at the end of the year 2020, Africa has just about 5,000 genomes. But because of the training and then the capacity building that we did, within 8 months of the next year, which is 2021, we went from 5,000 genomes to almost 100,000 genomes. So basically just really showing the impact and what we've been able to do, both locally and at a level with Nigeria, with Nigeria and Africa. But at Nigeria level, basically we use data, genome sequence data to actually provide information that the government actually uses to set policies. And that really has been what we've been able to do. Also within the network of the lab, of my lab, the SG, we've tested over 150,000, samples across, the areas where we're covering in Nigeria. Over. Thank you.
Great. Thank you, Christian, so much. Next, I'll move on to Nasia. Nasia, can you just talk a little bit about your role in all of this?
Yes, thank you so much, Jim. Hi, everyone. My name is Nasia Safdar. I'm a professor in infectious diseases, and during the pandemic, my role was as the medical director for infection control and prevention. And that meant making sure that the health system was prepared in terms of being able to deal with an influx of patients that were inevitably going to be coming in for care needed for COVID-19. And that meant thinking pretty broadly about things like protection of the healthcare workers, treatments for the patients, preparedness of the health system in terms of supplies, in terms of lab capacity, in terms of being able to think about how can a health system cope with an additional influx of patients in the midst of an already very busy situation with patients with not with COVID who also needed medical care, such as heart disease, trauma, strokes, and cancer as the big four. So of course, we weren't the only ones struggling with this issue, but I think health systems have really realized in this pandemic that they walk on this very fine line of taking care of a lot of patients, and even something that is a few more than what they're prepared for can really make it very difficult unless we are adequately prepared. And so I think some of those lessons that we'll talk about as we go on in this talk are things that we should all take to heart.
Great, really interesting. Amandine, why don't I let you go next?
Hi, everyone. So I'm Amandine. I'm a postdoctoral researcher at UCLA in California. And qualifying myself as a quantitative disease ecologist. So I use theoretical and data-driven models to try to link ecological dynamics with epidemiological dynamics across care. So it can be whether how viruses interact with proteins within a host, up to how different host species interact together, leading to pathogen transmission between different host species. And I'm particularly interested in pathogens that can have an impact on public health, but also biodiversity conservation, and how you can use ecological countermeasures to mitigate those pathogens. And in the context of this pandemic in particular, I've actually been focused more on the post-emergence aspect of the pandemic, so like the colleagues in the panel. And my main role was to work in collaboration with virologists to develop quantitative tools that could help us link all the knowledge virologists are generating in the lab to the epidemiological dynamics we observe in the field, and how we can use this knowledge to better inform the pandemic response. So for instance, how we can use translate results from stability experiments, measuring the stability of the virus in the environment, into a quantitative risk assessment for transmission, or how we can use animal experiments to really extract some information, quantitative information on the virus replication rate between different host species or across different virus variants.
So interesting. And last but not least, Steve, why don't you give an introduction and talk about your role in all of this?
Thank you very much, Jim. Thanks for organizing us. This is terrific. It's great to meet everyone here. Christian, we here in Washington, D.C., we're keenly awaiting the arrival of your colleague, John Nkengazong, who will soon be approved by the U.S. Senate as the head of our global AIDS program, PEPFAR. And I know it's a great loss for Africa CDC, but it's a great win. Frankly, he's a close friend. I know he must be a very close friend of yours. This network of people like yourselves have proven to be enormously valuable. I'm a political scientist. I'm at an independent, nonpartisan think tank in Washington, D.C. And prior to COVID, we had launched in the spring of 18 a commission looking at America's health security. And in November of 19, this was a fairly elaborate commission with a number of members of Congress on it, a number of very prominent experts. And just before the arrival of COVID, we had published a major study that made the argument that we were stuck in a cycle of crisis and complacency in our preparations for health security threats, for new pathogens that emerged. And we sort of outlined where the major weaknesses were in the US government and what needed to happen to fix them. When that first came out, there was some interest in Washington in this particular issue, but it was seen as a pretty dusty and boutique-y issue. Once COVID burst onto the scenes, of course, we looked less like nerds and more like prophets. And so we extended this task force and it will complete its work at the end of this year. As part of our work here, I mean, we're focused largely on trying to strengthen the US administration's approaches at home and particularly abroad in terms of the international response. That's the core preoccupation of our work. I also work at the Munich Security Conference for the last several years. We've also put together a podcast series predominantly focused on different perspectives in the United States response, but we've had people like John and Genghis come on for a few times. We just had the Chancellor of the University of Wisconsin, Rebecca Blank, come on last week. It's the Coronavirus Crisis Update is the name of the series. We started it February of 20, and she came on as the 129th episode. She appeared twice. In October, after the campus had been rocked really badly in August, September, and now on the eve of the conclusion of her 9-year tenure, reflecting on how the university had coped with the pandemic. Thanks very much, Jim.
Great, really interesting. And obviously, as people can see, we've got a wide array of people and their involvement in this pandemic. So let's start out briefly with just sort of seeing what we can agree were the things that actually went well with this pandemic. So if we can just go around and get some ideas from folks about what they actually thought that went well as far as a response to this new and emerging threat. I'll let any of you start and we can then go around. Or I'll call on somebody if I have to.
I can start. I guess, I don't know if everyone will agree, but I would assume so, that we just learned a lot about SARS-CoV-2. And so it was great during the pandemic, but I'm pretty sure that lots of the things we've learned will also be useful in the future for also things that we were considering not very important before, but now we know it's actually important. So for instance, the role of asymptomatic transmission in epidemiological dynamics. And since the SARS-CoV-2 outbreak pandemic started, we actually realized that it's also something that is probably very important for influenza viruses. Same for the role of aerosol transmission, which is not specific to SARS-CoV-2, but can also be applied to other viruses. And, we've been, in the US, we've been talking about, maybe people will keep on wearing masks when it's flu season in the US, or when they don't feel exactly all right and suspect they might be sick. And related to that, also the testing. Personally, I had never been tested for any infectious agent before. And so maybe that's something we'll keep, before you go visit a person at risk, you can get tested against the flu, against other coronaviruses and so on. And I guess the big development is also around RNA vaccines, which had been on the table for very long, but we are missing that push to implement them, and notably opportunities for clinical trials. And so I don't know, people with expertise in other infectious diseases might have something to say about this, but that could be a game changer in the future also for other infectious agents.
Great, thank you. Nasia, do you want to chip in here?
Yeah, sure. So yeah, I completely agree with you, Amandine. I think, the clinical trials infrastructure came together in a really important and really nice way, I think, to be able to identify the treatment options that we needed. Of course, there were still a lot of challenges and a lot of constraints, but some of the things that I think helped us were that a lot of the inflexibilities in prior clinical trials were lifted. You could consent participants virtually. You could make it easy for people all over the country to join, as long as, the treatment option was a relatively low risk or already available and that kind of thing. And so I think with those flexibilities came this opportunity then that you could really run large scale trials very efficiently, testing multiple agents at a time. Because really that's, what you need eventually in a pandemic is you need two things. You need a really effective preventive option and really effective treatment options. And so the trials help with both of those. I think without the vaccine, we would, despite all the other, non-pharmaceutical things that we talk about, like masks and distancing, we would not be anywhere near we are now without the vaccines. And so they really did change the trajectory of this pandemic. I think from the health system side, the things that worked well, would I say the tremendous collaboration that people saw in information sharing across health systems and realizing that we all were struggling with the same things. How could you move ventilators, PPE, those kinds of things to help patients? Because it was really a regional rolling pandemic. And so you could be in a surge in one part of the country and have gotten over that surge in the next. And so how to figure out those things, I think, was something that people were keen to do. Again, it was a lot like I think you said, Jim, sort of building the plane while flying it. There were many things that you tried to do that only to find out that, wasn't perfect. But certainly the spirit of collaboration, I think, was pretty immensely felt during this time.
Great. I'll add in that, two other things that I think were so interesting was the use of the Emergency Use Authorization, which had only been used for drugs previously, having that become something that was a tool for vaccines. And then, seeing that the otherwise bureaucratic and slow process of review at the FDA really could be made more efficient, certainly made all of those things a little bit more feasible and to happen in a shorter timeline. Christian, do you want to talk a little bit about things that you think went well with all of this?
Yeah, I can chip in. I think my other panelists have said a whole lot, and I absolutely agree with them on many of the things that they've said. From my own standpoint, I think data sharing was very important. We saw, an incredible amount of data deposited through GISED and then open data sharing and open data access. And that really accelerated, the vaccines that we actually saw produced. I think information sharing were very critical. And I do think that, we need to definitely, this is a model that should be adopted, but I also think that, in addition to such model, I think there should be some level of equity, that should be, included whilst we're talking about data sharing. And I can come back to that at some point in the future, later on. But, from the African standpoint, I would just speak from African perspective because that's really not often spoken about. And it is a fact that, there was a lot of coordination from the African standpoint, from Africa. And I think one of the reasons why you saw that, through the multiple wave, you didn't see the case fatality rate and the number of cases surge in Africa was really, a very strong collaboration and coordination among the member states on the continent through the Africa CDC that that you all know about. And this really is the fact that Africa learned a lot from the 2014-2016 Ebola outbreak in West Africa. And then after that outbreak, the African government or the head of state through the African Union established an agency that was responsible, to coordinate response of Africa to epidemic and to pandemics, and that's the Africa CDC. And that cooperation or that coordination was demonstrated because, as COVID started, in China, in the first week of January in Africa, there was a meeting of all African ministers of health, and where they actually came up with an agenda, and then they come up with a program very coordinated in how to respond, to this epidemic. And you could see Africa shutting down in unison at the same time, and then to prevent importation of cases in Africa. And we could also see a lot of a point when they were actually lifting the travel bans and everything. There was a lot of coordinated action, but it's also the fact that what I saw working from Africa perspective is actually cooperation. The centers and the countries that do have facilities were able to support those that did not have facilities. The countries that have sequencing ability were able to support those that did not have, and then made the data actionable for them to make policies. And then there was also a lot of capacity building into the process, helping people to do the testing, helping people to do the sequencing. And then also the fact that, a lot of Africans, were able to share information And that was very helpful in terms of helping the continent to navigate, this pandemic. People will be surprised because prior to the pandemic, there were models that actually forecasted millions and millions of African dead in the first six months of the epidemic or the pandemic. But unfortunately, the trajectory took a different turn. And this was simply because of this great coordination on the continent. This was simply due to the fact that, we all came together and then we were able to identify the local problems and then the needs, even without resources. We were able to navigate, the waves and then this pandemic efficiently. Thank you.
Terrific. And then Steve, I think you can be the cleanup hitter here on what you think actually went well from your perspective on all of this.
Well, much of what I'm going to say real quickly is a bit redundant. I think Africa CDC and AU were stars of the show in terms of global performers in this period for all the reasons that Christian's laid out. I think on the global side, which was largely marked by huge inequities and disarray and chaos, I do think the Biden administration deserves some credit for the leadership that it's shown in terms of the billion doses, the leadership at the G7, the summit from September, the new program just introduced in the budget yesterday, and the upcoming second summit that will be co-chaired with regional bodies like Africa CDC. In terms of the record, what happened ultimately in terms of a portfolio of super promising vaccines, it's now continuing to be developed. We're seeing the subproteins come online. We've got 65% of Americans vaccinated, and of those about, 45% with boosters. Those are achievements. Those are dramatic achievements. The industrial base that we have for vaccines, for testing, including at-home tests, for antivirals, the industrial base that we've built in these last 2 years plus is very, very impressive. We have an abundant supply of vaccines. We're doing better on capacity testing and on antivirals, and our stockpiles are looking better and better right now. So I think on the infrastructure side of things, some major gains, strong leadership from this administration. I think the White House COVID-19 group under Jeff Zients has performed very, very well. There are some gaps, there are some criticisms. He'll be stepping down and replaced by Ashish Jha, another very impressive leader in this field. But I think that creating a muscular, concentrated authority, initially in Operation Warp Speed, then transferring that over to the COVID-19 study, the COVID-19 group at the White House, and building a very strong team, and having that team taking a group of people who hid away for 6 months before the inauguration and wrote all of the planning documents that were all rolled out in the first day of this administration was an astonishing achievement. Thank you.
Do you want to take it and keep moving into the other side of the coin then, and talk about the things that you think went poorly? Because I think it's sort of a natural fit for you to keep, you're on a roll now.
All right, I'm on a roll. Okay, thank you. Well, the things that didn't go well, we're approaching 1 million dead. We have huge unanswered questions in front of us, long COVID being one of them, 5 million immunocompromised people in our country for whom we're not providing adequate enough protections. Our local and state public health authorities have been attacked and besieged, and they are resigning in droves. They're demoralized and under siege. We never created an effective track and trace and isolate capacity in local communities. Caregivers, those in the health system, are burned out, demoralized, and depleted. We have rampant mental health disorders and not much capacity or strategy for that. We have hesitancy and hardcore refusal among 14 to 16% of Americans. And we have a vast and extensive disinformation, misinformation, conspiracy theory that's driven down trust and confidence in our system. And everything that has happened here, every worthy tool that we've just talked about in the upside has been politicized in an environment that has become increasingly hardened and toxic in the United States in the last 12 months, so that every tool we have has been politicized, which is a tragedy and a terrible problem. Obviously, on the global side, it was disarray, and inequity was the signature piece of this. 14% of low-income countries today have had 2 doses of vaccine. That's roughly 50 percentage points lower than the average for high-income countries. So we still have a vast disparity in delivery capacity, in financing, and in vaccine access, even though the market, the global market on vaccines, has been swung into abundance in the last 6 months. I'll stop there. Thank you.
Great, thanks, Steve. Nasia, do you want to sort of add to things that you think have gone poorly, before we start talking about solutions to all this?
Yeah, I mean, I think that where does one even begin? In the early days of the pandemic, we all remember those photographs that came out from other parts of the world, from New York City, of people wearing trash bags to try and mimic PPE because there was no PPE to be had. I mean, those kinds of things you never really expect to find in this day and age. And yet here we were, testing capacity was severely limited. So you couldn't really diagnose the illness in people who were critically ill with it. You couldn't adequately protect the healthcare workers. And yet I think the expectation was that obviously when you take on this role as a healthcare worker, it's an occupational hazard. You will be exposed to things that might also hurt you. So I think people just leapt forward to help, not realizing the true scope of the problem and the fact that there would be no easy fix without really centralized administration and some sort of coordination. I think chaos is the right word to describe it. Everybody felt they were kind of on their own in the beginning, trying to figure out how to get resources for their own populations or their communities. I think the vulnerabilities that existed in the system were just completely exposed to the fact that ED systems could get overwhelmed, the fact that we didn't have enough ICU capacity or ventilator support for any kind of meaningful management of patients before vaccines and before really good therapeutic options. So all of those are really the things that kept many people up at night worrying about the infrastructure and how just fragile and precarious it was. And then ultimately, I think, this is what we know so far about how things have not gone well. But I think the true effects of this pandemic are going to only become apparent now and a few years from now, when we talk about, how far children have been left behind, what's happened to the female workforce during this whole time, how the effects of these disparities will play out in terms of outcomes. Well, we don't know about that, but I think we can all speculate that it will not be good.
Interesting, thank you. Amandine, do you want to share some ideas about other things that have gone poorly?
Yeah, I guess related to when you count in the end the number of deaths we had, I think we just wasted lots of time at the beginning because of things we could have known but we didn't know at the time. So for instance, I said we learned a lot of things about SARS-CoV-2 that could be translated for influenza and other coronaviruses, but I think if we used to invest more money in those pathogens that we considered just causing mild infections and not worth studying much, we would have been better prepared. So for instance, we could have known from studying influenza better, have people exposed to the potential usefulness of masks, for instance. So just, being more proactive in the way we consider infectious disease and not only react once things are already here. And another issue I think was related to the way things have been communicated, that we tend to communicate things as really in a really binary way. So for instance, there was our droplet versus aerosol transmission, and then it translated into that, okay, if you're less than 6 feet away from people, you're in danger, but if you're more than 6 feet away from people, you're safe. Instead of the fact that it's a gradient, it's things that are continuous and not just black and white like that. And same for I think that's also of my scope of expertise, but maybe people are other opinion, but we also classify people as anti-vax versus pro-vax instead of considering the multiple way people can be careful about taking a vaccine or worried about taking a vaccine and so on. So yeah, that's the main 2 points for me.
Wonderful. And then Christian, what are your thoughts on things that went poorly? And you can probably start talking about some of these equity issues that I think are so important as well.
Yeah, I do think that, at the beginning of the pandemic and even up to now, a lot of things really went very poorly. One of those things is vaccine nationalism, because it's really not acceptable that people, scientists and countries will agree to share data, and share genome sequence data, for instance, and then these genome sequence data are taken and then used to develop vaccines. And at the end of the day, some countries claim, the IPs and they refuse to share. So I mean, these are things that will drive, again, we'll block, in the future, people accepting to share data in platforms because they know exactly the outcome of those, of the sharing. So they should definitely, thinking about forward, there should be, there definitely should be an agreement among people and among nations that if data are shared, then the benefit from those data should be shared. So, and that's where the whole idea of equity comes into it. So those are, that's for me is one of those things that went very bad. And then the secondly is actually the fact that politics really got into, pandemic response. And then that really, eventually resulted in the loss of millions of lives that were not supposed to be. Our leadership actually failed the world globally in many ways because, instead of being more proactive and then more forward looking, people were more or less thinking about votes and the number of, and then thinking about, their political calculation than thinking than really being pragmatic in terms of helping, the global situation to respond to this epidemic. Then supply chain actually also what went wrong is the whole idea of supply chain, and then actually show, how what we call global cooperation actually can actually be broken down once it comes to, when we have a pandemic. We could see a situation whereby, countries that are having, we're talking about, countries agree together through platforms like COVAX, for instance, agreeing and then saying we're going to agree and support one another so that at the end of the day, we can curb this pandemic. But that such cooperation didn't work because, we have nationalistic sentiment. At the end of the day, instead of solving the problem, we fuel the problem and aggravated situation because we forgot to understand the fact that as long as transmission was getting to places, there were definitely going to be emergence of new variant that was actually threatening the countermeasures that we spent time developing. So these are some of those things that you could see in this pandemic really not working. And we hope that, moving forward, we could actually be more equitable in the way we're thinking. We could be more equitable and more pragmatic in the way we're thinking about, global public health in the future. So I think, what I think, that the other thing that I see that did not work is the fact that, we saw the global north not being responsible. And when I call about responsibility, actually the lack of leadership. So that's where the leadership should have come into. We're not saying that, that the countries in the South, even when they have the resources, but they couldn't even have access to vaccines. And it doesn't make sense, for a country to have 10 times the number of doses of vaccine that they ought to have, and then block it and then store those vaccines and prevent other people to have access, even with the resources, to vaccines in order to protect them and curb this pandemic. Thank you.
Well, really interesting, Christian. I want to get back to something that a couple of you have mentioned in this whole problem of the ambiguity of science and messaging and misinformation. And then we'll go back and talk about sort of policy things as well. But, a couple of you have sort of mentioned one of the problems being that, as Amandine said, there is a natural tendency when you're trying to simplify things for the public to try to make them simple in a way that makes them binomial, when in fact, I think most of us understand that science has a lot of gray zone and a lot of undiscovered things. But I think that, one of the things that was a challenge was trying to help the public understand that. I often talk about the fact that not only was this launching an airplane and building it while it was trying to fly, but also doing science in a fishbowl in a way that the public isn't really used to seeing. And I just wonder if you can talk a little bit about this issue of trying to convey science in a way that is actionable for the public, and how we get through this idea that this stuff has drifted into as much misinformation as information. Steve, do you want to start because you're unmuted?
Okay. I think we've had some really hard lessons in terms of communications in this period. The faith, trust, and confidence in the CDC, for instance, has deteriorated significantly in this period. I want to back up just a moment in this instance to say, look, during the Trump administration, CDC was singled out, as well as FDA, for special assault and abuse. And it's taken all sorts of forms, and it was highly damaging to those two institutions, but CDC in particular. And in this last phase, there's been repeated stumbles, including problems in communications, guidance, and the like. And there's got to be a wholesale rethink about how this institution connects to Americans and to its core constituencies in public health agencies and the like, and how data is communicated. And I think we're already beginning to see discussion of this in the curriculum of many schools of public health around the country that have been watching this unfold and asking themselves, why is it that it's not just a matter of that you're battling against a highly polarized and poisoned a toxic social media environment. That's part of it. Part of it also is that we're using tools that are 50 years old in terms of communication habits. And there's just a whole set of the population that is turned off from those.
What do you mean by 50-year-old tools for communication?
I mean, we are not using, well, 50-year-olds or 30-year-olds, but my point here is that we're not using the technologies in a deft fashion. We're not doing adequate enough nimble, fast, intelligible communications. We're slow. We speak in much too technocratic language, and we're playing catch up constantly. And beneath that is an eroded trust and confidence, and an anti-science sentiment that has seeped into the consciousness of a good 1/2 of the country. So it's an environment in which there needs to be a systematic rethink around communications and engagement.
Nasia, I wonder if you have some comments, since you were one of our major communicators from the health system and the university to the public here. You know, somebody put into the chat that, you know, initially there was some ideas based on the thought that this was like a typical respiratory virus that was primarily a droplet transmission, that the thought was that masks were not a primary mode. And as we discovered more, as Amandine mentioned earlier, about the aerosol component, that the messaging then had to change around masking. And yet that was perceived by the public as being either lying to the public or people not knowing what they were doing. Can you sort of talk about what could go better, or what might be a better approach, having learned from that experience and what it did?
Yeah, I think, you know, just as Amandine mentioned, I think this black and white approach that we sometimes take can be problematic, because I think in the early days of something that no one really has seen before, what can one possibly know for sure? You know, you do the best you can with the information that you have. But I think a really frequent big dose of humility to mention that, you know, this is what we know at this point, and then acknowledging that as things change. I mean, of course, there are lots of examples in history about interventions that have been done in the past that we no longer do, because over time science has proven them to either be unnecessary or harmful or whatever. But I think without that dose of humility, you know, if you pretend that you know everything and then you say something in a very dogmatic fashion, and then it turns out to not be the case, well, of course, people would say, you know, but this is what you said, and now you're changing your tune. So I think just framing it in that way is really important. I think the other thing that is really problematic for the public, and as a member of the public, if I, you know, being on the receiving end of those messages, I would find it very hard to believe if all the agencies were not completely aligned with each other. I mean, I trust the CDC very much for my own scientific information. And so if the CDC is saying one thing, for instance, and the NIH is saying another, and a third agency is saying something else altogether, well, what is the public to do? So I think there has to be some agreement that this is what we know we should do, and then everybody saying the same thing in a concerted, accurate manner without people sort of flailing off in different directions.
Wow, really, really insightful, really interesting. Christian and Amandine, you know, both of you have a major leg in the world of basic science with, you know, sequencing and detection of spillover viruses. Can you talk a little bit about the messaging of that, either to your colleagues or to the public? You know, Christian, as a leader within trying to coordinate things across Africa in dealing with ministers, you know, they're often not as scientifically savvy as the basic science people. How do you help them understand all of this information and make it into something that they can actually make into policy and action? And sort of how could we do that better going forward?
Yeah, I do think that the information has to be made simple. I think as scientists, we are not too good at communicating most of the time. And I think, the best way to make, information to a policymaker is actually to make it very simple and make it simple and understandable, actually to make somebody understand that, well, if you, for instance, keep letting, we need to prevent, transmission going on. And as long as we keep having transmission, then there's possibility that you have emergence of new viruses that will be very difficult to control. I think it's very important to show that. And but also to, we do all the sequencing work and then trying to show, but this is really not what a minister or somebody, the policymaker want to see. It is actually just to show the person, to make it in a kind of graphic and then in kind of visualization becomes very important because they want to see exactly trend. They want to see how things are moving around. And that becomes a very important thing for people in offices because that's exactly what they want to see. They want to see, decision, maybe they want to make decision based on evidence and the facts. But by the time you're presenting information in a way that are factual, not just necessarily numbers, I think, dashboards and then visualization became very important for people to really understand, use information and then use such information to actually make policies that could be very pragmatic and impactful.
Yeah, it's interesting. You're almost talking about the importance of not only sharing the information, but actually translating it into helping people understand what does it mean, is what you're sort of talking about. It kind of reminds me of the old Einstein.
That's right, correct.
The quote from Einstein, everything should be made as simple as possible, but no simpler. And there is sort of a sweet spot in there. Amandine, with the type of work you do, can you comment on sort of how that type of information that you generate and the modeling that you generate is translated in a way that becomes meaningful and actionable by people that are supposed to be setting policies?
So I will start by saying I completely agree with Christian, and I think it kind of meets the point that Steve was making earlier about how we use old-fashioned communication tools. And I think we shouldn't be scared about putting more interactive tools online because people actually use them. Like everyone was using that, that John Hopkins map of the number of cases. Like people would go on it and they would, look at different countries or like they would actually interact with it. And I think that could be a way, and people have tried to do it a little bit, but to build that more quantitative or less binary thinking in the public. So for instance, people have developed some apps where you could change some parameters and see what it means regarding how much viruses there would be left in the environment after some time or something like that. And I think that could be a way forward regarding this. And also to not completely, not just blame people on the communication side. I think as scientists, there are also things there are things that we could potentially modify maybe a little bit in the way we do science. So for instance, there are, the first paper that mentioned aerosol transmission, the potential for aerosol transmission was the New England Journal of Medicine paper published in March 2020, measuring the stability of SARS-CoV-2 on different surfaces and in aerosols. And at the time, I was a co-author on this paper, and we were really careful saying we have generated artificially those aerosols, so we don't know if that means that aerosols can actually be generated by a human, an infected human. So there's this mismatch between what we're measuring in the laboratory and what is happening in real life. And for instance, we acknowledge it and we think it's fine. We make people aware of it and then people can interpret, but it's not as easy. But there are things, for instance, like when we do animal experiments, we tend to use very high doses of virus because we want to make sure they will get infected so we can track the dynamic of the infection. But then there are some people in the public or in the more like public health, actually experts who are supposed to use the data we're generating, replying, but how it's not relevant and it doesn't represent a real world infection because you're using those ridiculously high doses, or you're putting the virus directly in the nose of the mouse instead of using a more natural way to expose them. So for instance, using aerosols or things like that. So there might be a, you know, a niche or like, yeah, like there is this intermediate step between what we're doing in the very basic science, where we're trying to understand what's happening when the virus infects a host. And maybe there's a link missing where we could do some experiments that are actually trying to capture a little bit more what's happening in the real life. So using things like lower doses or more realistic ways to expose animals and so on, which would make it, I think, easier for the public, but also the policymakers to directly translate the results from the experiments to something that is relevant to them, instead of having to guess how we would, you know, what it would correspond to in a real life situation.
Terrific. And that actually is a good segue into, let's talk as we finish up and then open it up to questions. You know, what kind of major policy changes in each of your spaces do you think need to happen to be able to be better prepared for the next pandemic? I want Christian to talk about it from sort of a global standpoint. I want Nasia to talk about it from sort of the healthcare industry, and Steve obviously to talk about it from sort of the global intersections of policy. And Amandine, I want you to talk about it in the scientific community. So Steve, you haven't talked on a little bit. So why don't you talk about sort of what are the major policy changes you think need to happen to get a better coordinated response between countries and between continents about something like this?
You mean on the international engagement side?
Yes, please. Yeah, and you can, certainly touch on domestic as well. But since this is the global health seminar, I want more on the intersection of where countries can come together to coordinate better.
Yeah, we've seen some movement in the last year in terms of efforts through the Independent Panel on Pandemic Preparedness and Response, that commission report, the high-level independent panel that the G20 put together. There's been lots of study done around identifying the nature of the problem and what's needed. There needs to be greater financing. Countries need to have better plans. There needs to be greater high-level coordination at the statesperson level. So the ideas are out there. The problem has been pulling people together in a world that still remains, as Omicron comes through and others come through, the nationalist tendencies still dominate in much of the response. And moreover, we've got a world that is divided into a strategic confrontation between the West and Russia now around the Ukraine, but also against China. And that creates cleavages that are really quite dangerous in a way. I mean, one of the biggest challenges we face today is the zero COVID crisis in China, as well as North Korea. We've written a lot about that. And we're seeing that manifest today as we speak. There's no dialogue around that in terms of the need for massive volume of mRNA and antivirals if China's going to get out of this and not experience something like Hong Kong has experienced recently, which is just tragic. So I do think you're going to see more G7 under Germany this year. You're going to see more calls for a unified approach. The Schultz and his people are being very vocal. I think you'll see the U.S. government pulling together to replenish the Global Fund in the fall at an $18 billion 3-year term, with the U.S. paying a third of that. They've got to now mobilize the other 2/3 from donors. That's a big number. It's a leap forward by $4 billion over 3 years from the previous cycle. So there are some ambitious things that are very multilateral. There's a treaty under discussion, a possibility of a international legal or diplomatic instrument that could address these inequities and capacity shortfalls and the like. That's just starting up. It's not aspiring to produce anything until a year from this spring, but that may turn out to be important. I think WHO and reform of WHO has been neglected. Reform of international health regulations neglected. Those things need far greater attention. Some of that intergovernmental negotiations around that treaty may be able to answer some of those questions. Thank you.
Great, thanks, Steve. And I think I'll push it over to Christian then. If you can talk a little bit about both the African continental coordination and also where you see the major policy possibilities? Is it at UN? Is it at WHO? Where would be the group that you think could drive the conversation to start to address some of these inequities between countries?
Yeah, thank you. There should be what I call a global conversation around, data sharing and what I call a return, return in investment in data sharing. So I think as long as that conversation is not holding, I'm afraid that, the next pandemic actually might be worse than the ones that we have now because countries will be refusing to share data. So I think there is a need for now to start really being truthful. Countries have to come and then to be truthful to themselves, learn from this pandemic and swear and commit not to repeat what we've seen, during this pandemic. So we can't afford to go forward with a situation whereby countries are not obliging and then where there is no what I call punishment for what I call delinquent nations, when people agree together to do things and then and some nation, because they believe they're so powerful, decide to do things the way they understand and then go unpunished. Because the consequences is that we have human lives that are lost, and then we have situation where pandemic cannot be controlled. I think there should be what I call a global treaty where people agree, to share information, and then, but also where people agree to share the benefit of the information that come from the information sharing, so that at the end of the day, people are more than willing to share data and then to share information, because otherwise we're just deceiving ourselves. So I think that, for me, I think is a conversation that needs to take place, and where people should be, truthful, and where there should be, strict guideline and then strict measures to punish nations that would not agree on agreement, will not comply with an agreement that they've actually entered. Only then you will see people having the necessary confidence in order to come back and then start sharing the data as it's done now. If you notice, recently, many countries, are refusing to share information because they realize that, sharing some of those information is at their own peril, and that has to change, and that confidence has to be built back. Now, talking about at the continental level, I think there is a need for Africa to realize that, we harbor probably the largest number of pathogens that have pandemic potential. There's a need to invest in this space, pandemic preparedness and response, but there's also a need for Africa to invest where its mouth and its brain is in thinking about developing the infrastructure, developing, and then also in terms of what I call the commodities. There's a need to build the industries in order to actually just help not only Africa, because I believe that Africa should ensure its health security. And by ensuring its own health security, we are going to be supporting and then and also supporting global health security. It's very important that, the policies in Africa are directed toward, self-reliance, self-confidence, and then setting up platforms that will support the continent, not only in developing the necessary countermeasures, that is vaccine therapeutics and then diagnostics, but also the medical commodities. Because only then Africa will actually reach, we'll say that we're independent. But in that process of independence, in building the Africa global health security, Africa health security, we will be supporting the world to respond to the global health security.
Thanks, Christian. Really interesting. So it sounds like we need major work at the UN to get some treaties, and WHO needs a major reform on disease surveillance and messaging. Nasia, can you talk a little bit about the healthcare industry itself? I think globally we've seen, just such a stretching of the capacity and barely able to even keep up with the pandemic, let alone all of the other routine activities. Do you have thoughts for what would be necessary to prevent this kind of mess that we've dealt with on the healthcare side of things?
Well, I think there's really two ways I think that we could try and approach it. So one is, I don't think there's anything better than Paul Farmer's 4S approach that we all may have heard about, which is that you need an abundance of space, stuff, systems, and staff. And so whether it's this pandemic or whether it's the next one, if you don't pay attention to those four things, then of course, you really can't do that in a vacuum. There's a finite amount of the workforce that has to be distributed across the country. So it can't be just a, my system first approach. It has to be really all health systems. So I think at the preparedness level, those are fundamental. And then the other, I think, is there will need to be a fundamental paradigm shift in how healthcare systems deliver healthcare. Historically, it's always been the patient comes to the health system for care. But as we've seen in COVID, that has put all kinds of barriers in the way of access to needed medical care. And so I think health systems need to be far more outward looking towards their communities, engaging with them in a much more meaningful way, really doing community-based participatory work, whether it's research, it's education, or it's medical care. I think those sort of relatively old-fashioned tools of, if you want to get your blood pressure checked, you have to make an appointment with a physician to do that and come to clinic and all of that. It really isn't sustainable in the long term. We have to just think about we're there to deliver care, not for people to come to us, but for us to go to them.
Really interesting. Amandine, you're going to get last word here before we move along. And one of the things that a couple of people have texted me is questions about what universities' role may be in better preparing people for this and future pandemics. I don't know if you have any thoughts as somebody who's been at a number of different educational organizations, including now at UCLA, if you have thoughts about where universities could be leads on being better prepared or helping communities and society be better prepared for these kinds of pandemics.
I just saw a question in the chat that I think, can I address that? I like it related to that we researchers are not necessarily trained for communication. We are trained to write peer-reviewed manuscript that we share with our peers, but we're not trained to communicate with the public. I don't know if we should be that. I feel like that's a completely different job, but there should be, maybe universities should invest into people who could make that bridge, either to communicate with the public or to communicate with policymakers. I guess that's something that could be done. And the other thing I think is not necessarily at the university level, but at the funding agency level. So the NIH, the National Health Institute of Health, the NSF, National Science Foundation, those big institutes that are funding most of the research that's happening in the US and they are equivalent in other countries. If they could be appealed by projects that are not necessarily focused just on the one sexy topic of the moment, maybe we could shift away from that very reactive way to produce research. So for instance, when COVID happened, so all those agencies offered a rapid funding scheme to study COVID, which is great. And it's a great thing that it happened. But also when the pandemic started, I was really surprised by the lack of data we actually had on what we call the endemic coronaviruses, or the seasonal ones, the ones that are causing the common cold. And I'm speculating here, but I suspect it's because it's just, it's a mild infection. It's not killing everyone. It's not, and actually that's probably not true. It is probably actually having some significant case fatality rate in population at risk, but it's just not a sexy research topic because it's not as dramatic. And if we had a better knowledge of how those viruses were working, maybe we would have been better prepared to the pandemic. For instance, knowing how long immunity is lasting against those viruses, because it's probably very close to what we could expect for SARS-CoV-2 and so on. And also related to that, and going back a little bit more to pandemic prevention, I think there has been in the last few years, since SARS-CoV-1 actually, and then Ebola, people have been made aware that bats where there was something special happening with bats. So there have been lots of research funding invested into studying viruses in bats. So there is lots of screening of viruses we can find in bats, which is mostly, people go, they collect samples in bat colonies, and then they sequence all the viruses they found there. But then we actually we have the sequences, but we don't really know what to do with them. Because, when you have a sequence, it doesn't tell you straight, like directly, whether the virus is actually going to be able to infect humans, to be pathogenic and so on. So, maybe in parallel to those wide screening, if we had some more in-depth studies on a few pathogens that we know can circulate between bats and humans, and I'm saying bats, but that also could be other species like rodents or actually any other wildlife species, that would be informative. And that also include screening other species and bats, because for Ebola, and so we still don't really know for SARS-CoV-2, but for Ebola, there have been cases where bats directly infected humans. It's been the case also for Nipah virus in Bangladesh, but in many cases, viruses actually spill over from human to wildlife through something like from wildlife to human through domestic species. And if we had a better surveillance at the domestic species level, I think we would be able to detect earlier pathogens before they actually, reach the situation we observed for SARS-CoV-2, where we only started reacting when we had big numbers of cases in humans.
Terrific. That was, as all of you as communicators know, sometimes it's better to answer the question the panel director should have asked rather than the one that they did ask. And that was really a great discussion of sort of where the basic science and surveillance needs to go. We're at the top of the hour. If you guys have a few minutes, I just wanted to give everybody a last chance to just sort of, in your dream world, what should the role of universities be? As a great university like the University of Wisconsin, a lot of the things that all of you are touching on all exist here on the campus. And one of the things the Global Health Institute tries to do is help partner those groups and get them to collaborate and build bridges between these places. But from your standpoint, when we think about sort of how we prevent or manage the next pandemic in a better fashion, what should the role of universities be as we prepare for that next challenge that we know is inevitable and down the road? Whoever wants to go first can go first.
Yeah, I can jump in here. I think that we need to, as university, to move out of the classrooms and really get down to the bushes, because that's where these things start. We need to work with the communities that are very close to to nature, and then to areas where we can have a human-animal interaction. So we need to invest, we need to develop, knowledge and then new novel technologies in order to, to set up what we call an early warning system for pandemic prevention and response. And this shouldn't just happen in the classroom. While new knowledge is being developed in the classroom, we need to move this really down to the field. And then most importantly, we need to actually build the system, strengthen the system, and also empower what I call frontline healthcare workers, because they're definitely going to be the ones that will actually, detect this early and then inform us. There is a need not only to develop smart, what I call intelligent diagnostics, next generation diagnostics. There is a need to develop and then deploy them into the field, into the front lines, as I mentioned. There is a need to actually just use information technology to actually communicate this information in their real time. Not only, globally, there is also a need for the university to think about, to empower frontline care workers to use both the smart or the intelligent diagnostic, next generation diagnostics, communicate this information in real time, and effectively make the information, also the information actionable for policymakers, in order for the world or people to actually to be more coordinated and then to be more accurate in the way they are taking actions. Because having lived through several epidemics in West Africa and having worked firsthand in all of those epidemics, I know that there are two things that are very important in order to curb or to prevent an outbreak or an epidemic or a pandemic. One is speed. There's a speed of execution and speed of information transfer. And then secondly is accuracy. So if we have speed and accuracy in everything that we do, as described, we'll be able to prevent or to contain quickly the next pandemic. Yes, it will start in the classroom, but it has to be really translated and then actually taken out of the classroom into the communities and where this should be implemented. That's where we should be spending most of our times and not in the classroom. Thank you.
Great, thank you, Christian. Steve, do you have any thoughts on how a university needs to move programs forward to try to manage the next pandemic in a better and more coordinated fashion?
Well, this was one of the topics in the conversation I had with the Chancellor Rebecca Blank in this recent podcast. Let me just say a few things. One is universities and colleges, many really distinguished themselves in terms of innovations and accomplishments in this period. And when you think about how dangerous the risk was of severe and protracted disruptions of campuses, and how close many did come, and yet they figured things out. And I think the contributions are several. One is obviously on R&D and private sector partnerships that come into that. We've seen much more of that. Investing in their own health infrastructure, including treatment of depression and other mental health disorders. Testing and communications. The University of Wisconsin dramatically upped its game in terms of its communications, not just to its own community, but beyond, in a state that is among the most divided politically during this pandemic in the United States, and it did quite well. It was able to win agreement to a common purpose within its population. I mean, 96% vaccination coverage without a mandate. That was through political engagement. That was through communications. That was through creating incentives and the like. I think universities have taught us a lot about how learning needs to change, and the sort of hybrid options and the different shakeups that occurred that brought forward new meaning of how to learn and how to impart knowledge in a way. But most importantly, universities taught us, many of them, the high performers taught us how to be safe, and advance science and create a community in the middle of this crisis. And those are going to stay with the universities. There's going to be a higher investment in the health infrastructure in most universities and colleges, and in data systems and the like. Thank you.
Thanks, Steve. And Nasia, do you want to sort of help close us down? And then Amandine, I'll give you the last word on sort of what the role of education and universities might be in managing the next pandemic.
Yeah, I think just as Steve mentioned, I think there were a lot of success stories from institutions of higher learning. And, they have sort of this dual complementary mission. One is to train the next generation in really cutting edge research and finding the frontiers and what is known and what is unknown. And that's something that only they can really do. There's all these talented students that come every year, and it's the job of those institutions to identify that talent and to enable it to be used for its full potential. And then I think the next step, parallel, is to engage with the community to build trust and relationships so that whatever information you put out then is widely regarded as a voice of trust and something that people would follow. I don't think these high vaccination rates would have been possible without those existing relationships, as people recognize that, what's being said is the right thing and also has the right intention behind it. So I think in this era of sort of skepticism towards science, those relationships are going to be what will save us, the public, and institutions of higher learning to move forward.
Yeah, it's so interesting because in most communities, the university is sort of considered a neutral power that really does cross over so many different boundaries that I think we've really discovered the importance of that in a state like Wisconsin. Amandine, do you have any last comments before we close down here?
Yeah, not really. Actually, I agree with what people said, and especially the last point that Nasia brought about. Yeah, the universities maybe acknowledging their role as a key source of information for local communities around them, and maybe we were talking about new ways to use new mediums of communication and to make that knowledge available to everyone. Maybe that's where as a researcher, I felt really supported for my research as a member of UCLA, and I know lots of my colleagues, there was a case too for their universities. I also felt relatively supported regarding teaching. I know there have been different opinions from different universities use different strategies. So some people were not as, some people had to teach in person while they didn't want to. Some people had to teach online while they didn't want to, and so on. UCLA went for a quite flexible way to do it, and so I felt really supported for that way. But it's really, again, with the communicating with the public. As a researcher, you have lots of research to manage, and I felt like if I had more support on someone who could actually put the time and already have the skills to translate my research into something that can be more easily accessible to the public and policymakers, for instance, by creating media that we could share or things like that. And I know most universities are services for that, but I think they're quite small compared to the university. And so usually you have to kind of run after them to benefit from this kind of support. So maybe invest more in those kind of services.
Well, that's terrific. And I can't thank our panelists enough for this conversation. We could go on for hours, I would think, as the audience continues to chip in some ideas. I want to thank everybody. I want to actually give credit that this kind of virtual meeting, I think, is actually going to be one of those things that does start to build these bridges and improve communication. I think that for many of us that work internationally, we can certainly decrease our carbon footprint and at the same time engage much more routinely with these kinds of things. I also want to give our panelists credit that this is the first Zoom panel I've ever been on that we didn't have to at any point say you're on mute. So I think we've all gotten extremely good at all of this. So I'm going to close it down, and thanks so much to Christian Happy, to Amandine Gamble, to Stephen Morrison, and to Nasia Safdar for sharing their thoughts today. It's been a great pleasure, and on behalf of the Global Health Institute, hopefully we'll see many of you at our next iteration at the Global Health Symposium on April 19th. Thanks, everyone. Stay well.
Thank you.
Thank you.
Thanks,
Thank you all so
everyone.
much. Thank you.
Thanks, everyone.